All right, hello everyone, and thank you for joining us today for our webinar on Accelerating Competence and Confidence in Obstetric Emergencies. My name is Caroline Falk, and I'm the Product Marketing Manager for the Services Portfolio here at Laerdal, and I'm gonna be your moderator today. So just some housekeeping before we get started. The webinar will be recorded and a link will be sent out early next week so you can rewatch the webinar. All participant lines will be muted, but we encourage you to utilize the chat feature for any comments and even when a presenter asks for some input. If you have questions though, please type them into the Q&A box as they come up to you and we'll answer them at the end. We have plenty of time for questions at the end. And now we're going to move on to our speakers. So from left to right, we have Peter Nielsen. Dr. Nielsen has been practicing maternal fetal medicine for 30 years and is board certified in obstetrics and gynecology and maternal fetal medicine as well. His clinical, academic, and leadership experience includes residency director, department chair, hospital CEO, consultant to the U.S. Army Surgeon General, and tenured professor during his 30 years of military experience. He is passionate about collaborative practice and team-based care and served on the American College of Obstetricians and Gynecologists Presidential Task Force Chair on Collaborative Practice in 2014, which outlined the best practices for team-based care and is endorsed by more than 20 national organizations. So thank you for joining us today, Peter.
Thank you for having me. It's an honor to be here.
Great, thank you. Next, we have Brian Bjorn. Brian is a patient safety manager here at Laerdal. He is a public health physician with more than 20 years experience in quality improvement and patient safety. Welcome, Brian.
Thank you, Caroline, and hi, everyone. Thank you for joining us today.
Great, and then last, we have Russell Smith. Russell is a registered nurse with over 19 years of experience in simulation. He is currently in the role of Business Development Manager at Laerdal, where he focuses on the development of simulation as a service with the intention of streamlining simulation results in healthcare. How are you doing today, Russell?
I'm great. Thank you, Caroline.
Great. Thank you, Russell, and thank you all for joining us today. Now we're going to dive into the agenda and see what we'll discuss. So many of you are here because you understand the importance of quality improvements in maternal care, and you've probably been searching for a way to better train your teams. But where do you find the time to train? So today we're going to dive into the trends and issues in maternal outcomes. We're even going to go over the Joint Commission guidelines for prenatal patient safety, and then we're going to tie it together to tell you how to improve your obstetric outcomes with simulation, and even introduce our new Laerdal Accelerate Program and tell you how to get started with that. And then lastly, we're going to have some time for some Q&A. So again, please enter your questions into the Q&A box, not the chat box, because that is different, but enter them as they come up and we'll answer them at the end. And now I'm going to pass it over to Brian, and he's going to begin talking about the maternity mortality crisis.
Thank you, Caroline. And I do want to encourage you to also use the chat. So if you have any comments, thoughts that come up during today's webinar, put them in the chat and let's get a good discussion going. We want to make this as interactive as we possibly can, given that it's a virtual event. So we wanted to start off by placing this topic of obstetric emergencies in a little bit of a context, and specifically the context of maternal health overall. Because we have a crisis in the United States, and the numbers are here on the screen telling you that. What you're looking at now is an illustration of how the maternal mortality rate, measured as pregnancy-related deaths per 100,000 live births, has changed in the United States over the last 3+ decades. And you will see that it has more than tripled. And you'll see that there's a particularly large jump over the last 2 years that we have data for, 2019 and 2020, the pandemic years. So numbers like this raises a whole range of questions. And one question is probably, is this a uniquely American problem? Do other countries struggle with the same problem? If it is a uniquely American problem, why is that? How come a country that rightfully prides itself on its healthcare innovation and that is home to some of the best hospitals in the world, has a highly educated, highly motivated healthcare workforce, why do we see such numbers? So let's make that international comparison, and let's first look at our neighbors to the north, Canada. So when we add Canada to the mix here, it becomes clear that something is happening in the United States that we don't see in other countries. Canada is actually very representative of other high income nations. And to me, two things stand out when looking at the Canadian numbers. One is that they are at about half the rate of mortality that we are. And the other is that they have been able to keep it steady over the last 2 decades. Now, they're not getting any better, but they're also not getting any worse. So let's add a third country to the mix, a country that represents kind of best in class performance. And the country we're looking at here is Norway. What stands out to me when I look at this graph is that Norway started out already much better than both Canada and the United States. And nonetheless, they've been able to continue to improve. They are now cut, over the last 20 years, they have cut their maternal mortality rate by 2/3. So something is obviously happening, and I want to hear from you. So on the next slide, please, in the chat, and we're gonna hang tight on this slide for probably 30 seconds or so, but that shouldn't stop you from adding comments in the chat. I want to hear from you thoughts on what are the factors driving this? Why do we see these numbers in the United States and not in other countries? So please join the discussion in the chat. If you might have a problem finding the chat. If that's the case, if you hover with your mouse over the bottom of your screen, you should see a little menu pop up, and you'll see a chat. You can click that, and to the right, the chat panel will pop up. I see one comment: lack of prenatal care, more chronic health problems, ethnicity. Keep them coming. This is great. Any other suggestions? Health disparities, lack of access, culture. These are all great examples of factors that are driving these outcomes. Poor economics. So let's take a closer look at one of these factors. And please keep them coming. I can't comment on all of them as we go, but please keep adding in the chat. If we go to the next slide, I think we need to address one set of factors up front, because you probably would agree with me that this in and of itself is a call to action. We have tremendous racial and ethnic disparities in outcomes, not only in obstetrics. This really goes across all of healthcare. A non-Hispanic Black person is more than 5 times more likely to die from a pregnancy-related condition than a non-Hispanic white person in America. And I think it's worth mentioning here that we actually do know that simulation is one of the tools you can use to ensure that your healthcare workforce, your staff, and your providers are actually properly trained and prepared to care for diverse populations in an equitable fashion. So let's take a deeper dive into some of the many factors that you have added in the chat. And please, thank you so much for adding those. Keep them coming. We want to try to kind of organize them to get, because it can be overwhelming with so many factors. We want to kind of narrow down on where can we as individuals maybe start. And I'm not saying that means that you should only stay in your own lane. I'm just saying that might be where you have the biggest chance of having an immediate impact. So let's try to look at these factors and think of them as a hierarchy. At the bottom of this pyramid, we have societal factors. Those are going to influence everything that happens in the levels above them in the pyramid. We've already talked about some of them in the chat. Racial disparities, lack of education is coming up here, implicit bias. Those are all factors that belong at societal level. Cultural norms, public policies, they all affect what happens in healthcare. Once we move inside healthcare, factors that could affect outcomes would be access to care, both in terms of, do you have insurance? Do you have enough insurance? Do you have the right insurance? But also, is there a facility that you can actually get to when you need care? Is there public transportation available if you can't drive yourself there? And then as we move closer and closer to the facility level, the provider level, could be factors like patient-centered care. Are we actually truly providing patient-centered care? Are we providing what we would call risk-appropriate care, meaning that we are only caring for patients that we can actually safely care for? And then finally, we can get to the top of the pyramid where we find all the individual factors. Some of them are just what they are. Age, there's not too much we can do about that when the person is pregnant. Parity is also something we can't really do anything about, but there could be factors like tobacco use, overweight that can potentially be addressed. So what we're going to, what I'm trying to say here is we understand that this is not an easy problem to solve, because if it were, you would have already done so. And I'm hoping that no one at this point feels completely overwhelmed and ready to throw up their arms in despair, because really we're trying to get closer to where we can make an impact. And one way to think of that is to think about where in your daily work do you have a problem that is both prevalent and preventable. Because let me give you a couple of examples. Let's say you have something that is prevalent. Maybe 2/3 of your patients experience this problem, but no one knows how to prevent it. No one knows what the solution is. That's not a very great opportunity for improvement. It is certainly important, and it's probably something that someone should do some research on, but it's not really an opportunity for improvement. There's nothing you can do about it. Conversely, if you have something that you know exactly how to prevent, but it basically never happens in your patient population, I'm not saying it's not important. I'm not saying you shouldn't fix it if it's easy to do, but there's just not a lot of opportunity for improvement there. What you want to focus on is something that is prevalent and preventable. And it just so happens that there are 2 obstetric emergencies that fit that bill. Maternal hemorrhage and hypertension are both 2 of the leading causes of maternal death, and they're also considered highly preventable. That is probably also why the Joint Commission has focused on those 2 conditions in their perinatal safety program. We can go to the next slide, please. So the Joint Commission has put standards together to address this maternal health crisis, and they are specifically around maternal hemorrhage and maternal severe hypertension. There are 5 elements in those 2 standards that are shared between the standards, and then there are 2 elements that are specific to hemorrhage. The 2 that are specific to hemorrhage are the requirement that you risk assess all patients on admission and that you have a dedicated hemorrhage supply kit. The 5 that are shared between the 2 standards are having a written procedure in place. It has to be evidence-based. It has to be updated at certain intervals. And those of you who are as gray as I am will think back and know that this was the bar back in the olden times for Joint Commission accreditation. If you had the policy, you could keep it in the drawer, and when the surveyors walked into the building, you could pull it out, and everyone was happy. That has changed many years ago, and you're now being measured also on whether your staff knows the policy and they're actually using it. Which leads to the next element in these 2 standards, which is education. You have to provide education on your procedures for all staff and providers who care for these patients, on orientation whenever you change the procedure, or at least every 2 years. I'm probably not allowed to have favorites when it comes to Joint Commission standards, but I do have a favorite anyways. It's the drill. It's a requirement that you do a drill in these 2 areas at least once a year. They have to be multidisciplinary, and they are really a great way of pressure testing your system. That's where you find out if those written procedures and all that education is actually working the way you think it works. And finally, the last 2 elements of the standards are a requirement that you review all cases so that you can learn from the outcomes, and that you provide patient education so that your patients can play an active role in their own care, and so that they can play an active role in keeping themselves safe. And I think it's important to realize that this is not really meant to be a check the boxes exercise. All these elements have to be in place because they all drive towards the outcomes that you are aiming for. And in our specific context, the outcomes that we are aiming for are a reduction in our excess maternal mortality and ultimately a resolution of the maternal health crisis in the United States. So with that, I want to hand it over to Dr. Nielsen, who is going to give some more closer to the front line examples of how this all works. Over to you, Peter.
Thank you, Brian. It was a very good review and appreciate your comments. So many of you have heard of high reliability as a concept. I want to just dive into this a little bit. A high reliability organization is an organization that's managed to avoid most catastrophic failure despite operating on a high risk and high complex environment. Healthcare fits into that category for sure. Examples outside of healthcare that many of you are probably aware of have included aviation and nuclear power generation. There are, however, few examples within healthcare that have mastered this. Some that have done it better than others include anesthesia and transfusion medicine. In situ simulation-based team training can help strengthen all 5 pillars of this high reliability process and the foundation, the safety culture of the organization. In particular, in situ simulation can be used to identify system issues, ideally before they have a chance to impact patient care. And clinical drills can be used to stress test hospital and department guidelines and protocols, as Brian mentioned, helping to better error-proof the system by finding holes in the Swiss cheese, as it were. Simulation by nature includes the frontline healthcare workers, which is where the expertise is, offering deference to expertise. And done correctly, simulation in situ, meaning in the location where these experts work, can be an important component in a hospital's patient safety and quality improvement program. Next slide. So the goal of in situ clinical team drills is to produce a learning organization in which potential problems are anticipated, detected early, and virtually always responded to optimally and early enough to prevent catastrophic consequences. In fact, many programs, including levels of maternal care, in addition to the Joint Commission, require linking these drills to hospital quality assurance and performance improvement, or QAPI programs, and drill simulations, therefore providing feedback to the QAPI committee. The effect of using obstetric hemorrhage bundles on severe maternal morbidity and racial disparities was actually recently published by Elliot Main and colleagues from California, and provides clear evidence that these bundles can positively impact both outcomes. In this particular study, published in the American Journal of Obstetric and Gynecology in 2020, post-intervention rates of severe maternal morbidity due to hemorrhage were reduced in all races, and the benefit among Black women exceeded that of white women, 9% versus 2% absolute rate of reduction. In addition, ensuring in situ clinical team practice drills using these bundles to stress test the internal guidelines and protocols can further increase the likelihood of reducing severe maternal morbidity and mortality, and further positively impact disparities amongst races and other individual groups. In fact, I've personally seen demonstrable improvement in both patient safety culture surveys and in actual team performance and clinical outcomes for numerous obstetric emergencies, including obstetric and hypertension, as I've been personally involved with the most early work in simulation-based clinical drills and team training over my 30-year career. Next slide. So this cartoon is an example of a potential QAPI flow. The goal of in situ simulation-based training, as we've talked about, is not just to improve the skills of an individual or a team, but it's also to ensure that those improved skills translate into improved processes that can ultimately lead to improved patient outcomes, especially through linkage to QAPI programs. Therefore, in situ simulation is a unique learning modality that leads not only to individual and team learning, but to organizational learning. This diagram shows an example of just how this linkage could work. Severe maternal morbidity, in the top of the slide, is identified through data capture and review of each event. Areas of potential improvement are identified, and the guidelines and protocols, again, stress tested in simulation-based team training drills in the actual units where these conditions might be encountered, which in this case includes labor and delivery, emergency departments, and ICUs, as well as postpartum areas of postpartum care, which sometimes, frankly, are overlooked in my personal experience. Areas of process improvement are documented in these drills from feedback from those closest to the clinical situations and with the most expertise, who really know what's happening and really understand what impedes their ability to make these processes better on the ground. Clinical practice guidelines, protocols are then adjusted and surveillance for severe maternal morbidity continues, and the process cycles again. I think this shows a pretty good diagrammatic flow of this process, and I hope this helps you understand how QAPI can be introduced and integrated into simulation-based team training and drills. I'll now hand this presentation over to Russell, who will take it on home. Thank you.
Thank you very much, Dr. Nielsen. So we'd like to hear from you again at this point. If you wouldn't mind entering into the chat, what type of barriers are you facing when it comes to doing team-based training in the hospital? Buy-in, thank you. Physician buy-in, okay, so more specificity there. Staffing, there's another buy-in. Time, mannequins and equipment, okay. All right, so you've already got the things that are going on in the hospital and the census, and you can't really control that, so, and COVID. All right. Thank you for that. Please feel free to keep adding to the chat. And from here, I'll just go ahead and say thanks for sharing with the barriers. And the chances are you're not alone in these challenges. There are some very well-established hardships, and I'll summarize quickly. Capital purchase approvals and maintaining the equipment and competence with the equipment, staff turnover. You've got to provide some return on that investment and be able to prove it. Evaluating SIM, somebody just mentioned multidisciplinary, and that's another, almost makes the matrix of learning objectives three-dimensional, doesn't it? So all of this in the interest of creating lasting change, right? And that's what we want to be able to get to with using simulation as a tool. So that lasting change really requires application of what we're learning through the QAPI process. And for that to happen, well, there needs to be some measurability. When we capture metrics that are important, we can benchmark, we can revise processes, we can prove competence, and ultimately, we're striving to improve patient safety. We go to the next slide, please. All right. So we know that data is key to measuring impact, measuring progress, and it's also very important in team-based training as well. So in the example that you're seeing here, the graph on the left shows each cohort or team of participants attempting to meet certain criteria over time in a simulation experience. What you can see is that the time to successful completion of the objectives varies widely from team to team. So now if you focus on the graph to the right, what you'll see is the same set of teams after training and repeating the experience. So the time to completion is significantly reduced. And as we would say in the military, it's a tight shot group, right? Every team performs relatively close to all the others. The metrics in the graph I'm showing is time over successful completion of certain tasks. I'm speaking in relative terms because this applies across disciplines. But now if we specifically think about this in terms of obstetrics, if we apply the criteria from the Joint Commission that we have the means, we've got the means to do a whole lot more than just check the box on having met the requirement. If this graph were representative of like time to identification, team activation, transfusion protocol, medication delivery, hemorrhage control, vital sign stabilization, whatever that criteria may be, we have significant opportunity to use the data to create that meaningful change and, well, prove it. So go ahead on, please, to the next slide. All right, so here I'll take a moment to just reflect on 3 important highlights. First of all, we know simulation is a validated method for team training. It's validated for competency development, and it has the potential for improving patient safety. Now, this is well established in other high reliability domains. It's very much supported by the results from the airline industry safety movement. The changes that they have made over the years provides a culture of safety that's referenced frequently as an example for others who are striving for a zero harm environment. Second, we know there's movement in the direction of team-based training by organizations like the Joint Commission, which provides a very focused starting point with hemorrhage and hypertension. So we don't need to look very far to know where to begin, which sometimes is difficult to do with simulation. Third, well, we recognize that there are burdens associated with launching a simulation program, and we mentioned them. It's capital expense, it's buy-in, it's planning, staffing, the implementation part, and evaluating the results and getting to that return on investment. So if you are looking for a way to get started or looking to increase your capacity with SIM, we're eager to help you. For years now, we've been providing mobile simulation, which is helping to address gaps in nurse onboarding, education, and many other aspects. So now, as we apply what we've learned to the 3 things that I summarized, we see a great opportunity to partner with your organization to help meet you wherever you are on your journey to excellence, and really to get right down to the business of doing simulation, collecting data, proving competence, and ultimately creating that meaningful change. This is our Accelerate program. We bring the solution to you, whether that is equipment, technical operators, or every aspect in the development process. So if you have no real sim program, you don't know where to start, and you have some equipment, but you don't know how to systemize it, or you have a sim program, but you want to drill in on some specific use cases, we welcome the opportunity to partner with you on that journey. Next slide, please.
All right, so now we're going to take some Q&A. Please enter them into the Q&A chat. We're just going to start going down them, so start getting those in there. But I have one right here. I think it's around what you just talked about, Russell. So how does a program like this address disparities of care?
That is a great question. And so I think we should open that up to the entire panel.
Russell, I think I can maybe help with that a little bit. So let me just give you an example from my military experience, my combat deployment experience. I worked in numerous combat support hospitals while I was on active duty, and they used gynecologic surgeons as additional surgical team members for combat trauma related activities. And while that's not typically discussed among most obstetric and gynecologic surgeons in the military, it's sort of what we do. So from that perspective, we also took care of patients that were not just U.S. forces when we were deployed. We took care of civilians, enemy combatants, local national folks, anybody who showed up. And the reality is that we implemented strategies and tactics and drills within military combat support hospitals to respond in the most timely, efficient, and consistent manner to anyone who was injured, to be honest. And there was no effort to try and figure out what the person was or who they were prior to injury. Sometimes you couldn't tell anyway. And And our outcome data from that experience over 15 plus years demonstrated that we could impact outcomes equally, regardless of who those patients were. And so I think the strategy of implementing standardized approaches every time with teams that are well-trained and teams that are highly motivated and teams that collaborate, coordinate, and communicate is simply the key. And I think that reduces for sure, potentially eliminates the potential that there's going to be introduced some sort of bias that results in worse outcomes for some groups of people than others, other than the components of things that you can't change, which is their initial injury. So that would be my answer to that question. And I think some of the data that's coming out of Elliot Main's team from the CMQCC in California and other places is clearly beginning to demonstrate that that's possible. And I think clearly the military has demonstrated that over many years of its combat support care and casualty care that many of you may not be familiar with, but I'm intimately familiar with, and I can tell you it works.
If
I would add on that. Hello, everyone. I'm Clint Pridge, and I work with Laerdal closely with many of the members you see here. And I think what you'll hear from Peter, and I even tie it back to one of the comments about buy-in, is the role that data plays. And as we have worked with numerous customers and healthcare organizations, part of what we found is everyone is doing a lot of good work, but the challenge is, how do I show the impact, right? Or how do we make determinations of, we've done X, when we do this again in 6 months, where do we really focus our efforts? And so if you look at the data that Russell showed, or you look at some of the references that Pierre provided, one of the key components of what we're doing when we partner with organizations is bringing in a mechanism to capture that data and translate it into insights. To say, you need to create buy-in. Well, let me show you what the average time to competency was. Let's look at some key indices of what happens repeatedly in a control group versus a non-control group. And what we found is that has created tremendous momentum for organizations to be able to not only justify the spend, but also create a paradigm for continuous improvement. So it's not, we're Groundhog Day, we're basically doing the same drills over and over again. It's, we're doing a set of drills, and the next time we come in, based on the data that we have, we know where we begin to pivot our next iterative effort. You know, it may not be that we need to do skills 1 through 3 because we had a 95% pass rate the first time through, but we really need to focus in on skill 4. And I think that is, as we have worked with partners and talked to many of the leaders in the organization, that really is where this is going to be able to demonstrate impact and create outcome improvement.
That's Clint. I think that's a great comment. And I will take one more opportunity to just give you a real-time example of this from my military experience, and that is the Joint Theater Trauma Registry. Many of you may never have heard of it before, but the Joint Theater Trauma Registry was created in order for us to capture data around trauma outcomes from our many years in combat in the last 15, 20 years, in order to improve processes and then feed that back to the people on the ground and those teams. And there have been literally thousands of papers written out of the Joint Theater Trauma Registry that have documented improvements in trauma outcomes associated with entire groups of patients from the Iraq and Afghanistan theaters that we don't have. It's not the venue to go into, but I can just tell you that 100% it improves. But you have to capture the data. You have to use the data. It has to be actionable intelligence, as we say. And you have to then do something about it and implement that strategy. And so that's the example, I think, from the military healthcare system, combat casualty care system, frankly, that can be used by civilians for any, like me now, right? For any team-based healthcare intervention that you want to improve. Doesn't matter what it is. Doesn't even matter where you are. Because I can guarantee you, we were in places that don't have the resources in some instances, or some of the circumstances that places in the United States and other countries do now, and it is doable.
Thank you, Peter. Caroline, any more questions?
Yeah, so we have one. It's around the same, a little bit of the same lines that you guys were talking about. How do I assess the benefit or justify the cost to my organization?
That's a great question, and quite frankly, I'll give a little color, and then I'll ask the team to weigh in. You know, the reality is part of it is the sunk cost fallacy, which is these efforts and activity are ongoing already. And in fact, it becomes a question of are we doing it because we're doing a check the box exercise? Are we doing it because we believe it's making a meaningful difference? And so, you know, part of the conversation we just had about data really drives that corollary of showing we're doing it because we believe that it shows a tangible outcome. You know, the other piece from a cost benefit perspective is we all know the nursing crisis is full bore right now, right? And not just nursing, healthcare practitioners in general. And one of the things that is highlighted when looking at groups of practitioners about what drives their decision to stay is the relative investment in their skill set and their ability to impact patient care. And so what we've seen anecdotally is programs that actually incorporate team-based training with regularity have higher employee satisfaction scores that help to drive and be a bit of a salve against some of the attrition that's taking place. You know, Brian, Peter, Russell, I'd ask you from your clinical experience, what have you seen as far as mechanisms to say, okay, what do we really do to demonstrate justification?
I believe the ability to collect data and to show that return on investment through the numbers and being able to speak the language that is important to the decision makers is a critical component. I just my sort of knee jerk on that is if we kind of flip that question around to this. If there are things that we can be doing to perform better as a team that are showing positive results, then how can we afford not to do them? And I'll turn that over to Brian.
Thank you, Russell. I think so. One of the things we're trying to do here is take it kind of a step further than people typically do, because we're good at measuring the immediate educational outcome of simulation, but we really want to get to the step where we also measure its impact on outcomes. So if we're looking, for example, at postpartum hemorrhage as one example, it's one of the scenarios we're working on. We would encourage all hospitals that are doing simulations in that area to track a couple of metrics to see that it's actually changing things on the clinical end. So for example, we would encourage them to track what is the rate of postpartum hemorrhage in their hospital. And we would actually expect that number to go up initially after they start some training programs, because they're probably going to identify more cases correctly. And the other aspect we would ask them to measure, because it's really hard to measure mortality, because thankfully these are rare events at the hospital level. But one way of tracking that is to track, for example, the use of massive transfusion protocols, or just overall the use of blood per delivery. So that's a way to directly link what you're doing in simulation to what impact does it have on your patients.
Yeah, those are good metrics, Brian. Even more specifically, looking at the two things that drive most of the mortality around hemorrhage, which include number of units of blood transfused and ICU admission requirement, or ventilatory support requirement, or all three. And so looking at the prevalence of 4 or more units of blood products transfused, or ICU admission, or requirement for intubation and ventilation in those patients is also an indirect measure of evaluating the effect of this team-based in situ clinical training on potential reduction in in mortality. Because if you can reduce morbidity and you can reduce the rates of those morbid events that those rates of morbid events that could result in mortality, then you will reduce mortality.
All right, please keep entering your questions into the Q&A, but our next one here is, prevention is key. So how is this a step towards prevention?
I mean, I can take that as an example for hemorrhage. The Joint Commission is requiring, and frankly, many people have already been doing this, is risk assessment, not only on admission, but risk assessment ongoing for obstetric hemorrhage, ongoing during their patient's admission, typically for labor, and reassessment of that risk. And risk assessment can be helpful, but risk assessment without preparation or planning or practice really isn't helpful. And so I think that's one of the ways in which prevention, as an example, can be a strategy can be implemented. But obstetric hemorrhage is not 100% preventable in terms of, you won't prevent every single case of less than 1,000 or more than 1,000 cc blood loss, for example. But what can be preventable is the rates of severe maternal morbidity that can result from that hemorrhage, and therefore getting ahead of the hemorrhage, right? Staying ahead of the hemorrhage and reducing the likelihood for needing any blood products transfused or any ICU admission or any ventilatory support is really the goal.
And I think if I may add to that, the clinical drills, the in situ simulation, those are really powerful tools in terms of prevention, because not only are going to work on your individual and your team-based skills when you do those, you're going to find those holes in the Swiss cheese that you didn't even know you had. So you're going to find this patient safety issues that you need to address. You can actually use the next drill then to see if you fix the problem.
I think the other issue around preventability is ensuring that you have all team members participate in these drills. It says requirement for annual team drills, but annual team drills done with the same people in a small group of people that work there, and 98% of the other people that participate in healthcare activities at the hospital don't participate in drills isn't really going to be helpful. So it's got to be everybody's got to participate.
All right, thank you. So looks like our last question here is probably more towards Russell. It's about the Accelerate program. How many people can be taught in one session, and just how does this work?
Sure. So let me try to approach the first part of that about the number of people who can be taught. And if we go back to what the Joint Commission has laid out, is that we really need to train everyone. That would be all in the OB unit. It would be all floors. Anyone who is going to be part of your system that's in place for responding to a hemorrhage emergency. This gives the opportunity to train everyone as a team. Train the team for responding appropriately to those emergencies, and really to challenge the system and to test your policies and procedures. There isn't really a limit to the amount of people that we can train. So the second part of the question is how does this work? And this would just start with a great conversation around where you are in your journey, and we'll begin to fill in the gaps with the types of things that we need to be able to help you along the way. So maybe that's the equipment and the operator and content and the data collection capabilities with reporting, and maybe it's just a component or two inside of that.
I would add to that, I think it's a great comment by Russell that if we've learned anything through our 80 years of working with healthcare organizations, is there's not a one-size-fits-all approach. And especially as you think about the QAPI process and we even look at the different administration, right? Some of you are running these quality programs through your quality officers. Some are running it through the CNO. Some are having a varied degree and a hybrid approach with different entities in your organization. So what we pride ourselves on really is partnering with you in this journey, because you guys really are the heroes. You're the ones on the front line. So we customize the program to work with you, right? Based on where you are on your journey. To Russell's point, for some people, the easiest thing are going, look, we're cutting our teeth. Give us the content, the operators, the equipment, bring it in. Let's schedule a day and a half. We're going to have some folks that are going to call audibles and then take it out. I don't want to worry about the logistics. I don't want to worry about the headaches. I want to be able to bring it in and bring it out. There are going to be other organizations that say, man, we've got equipment in place. We've got really good curriculum. We just need some help. We need some operators. We need some ideas on how we're going to measure this, right? So we can demonstrate impact. Wherever you happen to be in that journey, I think it's a great conversation and an opportunity to move forward. And I think to that end, we would love to have some conversations about the metrics as well. Brian, can you speak a little bit in closing about some of the work that's ongoing with Peter and others about advisory boards and metrics and how we're looking at translating some of these into real-time outcomes?
Sure thing. So we are looking for basically for every. We're building out initially some services around obstetric emergencies, and we want to make sure that we have an ability to track the impact we're having on patient care. So for every kind of bundles of scenarios, if you will, we will have a suggested measure slate that covers everything. I know that a lot of attendees are educators, so we're kind of using the Kirkpatrick framework. So we're going to track everything from how do the participants respond to the training and all the way up to what impact does it have on your patients. And as Glenn mentioned, we are looking for partnerships with those of you who might be interested in working with us in an advisory board capacity or in focus groups so that we can learn more about how we can best help you save lives.
Great. I thought that went really smoothly into this next slide. So just to kind of wrap up a little bit here, if the Laerdal Accelerate program piqued your interest and how this is a turnkey solution, it could be great for your organization. I encourage you to reach out to your local client executive or head to laerdal.com/managed services. And then, like Brian just said, if you're interested in that, his email is here. So please reach out to him if you're interested in that. And then that brings us to the close of our webinar. So as a reminder, the webinar will be recorded and it will be sent out early next week to you all so you can watch it again. And I thank you all for joining us today and hope you were able to realize the crisis and how Laerdal is here to help. Any last words, guys?
I just want to thank everyone for joining the conversation today. Great comments in the chat. It was really a pleasure having you all here.
Yeah, I agree, Brian. Thank you very much for all the comments, the discussion, the great insights, and the participation by everyone on the call.
I agree. Thank you all. We're here to help. Please feel free to reach out.
All right, great. Thank you, everyone, and have a great day.